Good evening, everyone. I'm Dr. Ali Bernard Khalil. I'm a consultant at Imperial London Diabetes Center, Abu Dhabi. It's a great honor, actually, to be chairing the session of tonight. For this, I would like to thank Dr. Wiam and the organizing committee for asking me to be a moderator for this, both the upcoming two sessions. I'm sure you will enjoy two eminent speakers. For this, let me first introduce the first speaker. The first speaker is Dr. Thamer Al-Isa. Dr. Thamer is a consultant endocrinologist and diabetes at Mubarak Al-Kabir Hospital and the Smart Diabetes Institute. Dr. Thamer got his MD from University of Kuwait. Then he did his training in internal medicine and endocrinology at the University of Miami. And he's American board in both internal medicine and endocrinology, as well as fellow of the American College of Endocrinology. He's certified in clinical densitometry and he's vice president of the Kuwait Osteoporosis Society. He's a member of several national and international committees and organizations, and he will be rightly the person to address the topic of tonight, update on osteoporosis guidelines. Dr. Thamer, the floor is yours.
Thank you, Dr. Ali. Appreciate the introduction. Thank you all for attending. Would like to thank the organizing committee, Dr. Wiam, for the kind invitation to present to you today. So without much delay, we can start my presentation. Okay, so I'll talk a little bit today about some updates in osteoporosis guidelines, things mainly related to the diagnosis and some part of management related to osteoporosis. These are my disclosures. So osteoporosis definitely is a major global threat to healthy aging countries with large populations, especially in the senior populations, because they anticipate to carry the biggest burden related to osteoporosis. And in recent publication by Dr. Yusuf Al-Saleh, they mentioned in the Saudi Arabia, this is estimated total number of hip fractures in men and women that is above the age of 50 or older is projected to increase nearly 7-fold up to 2050. That's a lot of burden in terms of management and protection also. Still, worldwide variation has been reported in the incidence of osteoporosis, specifically about different types of fractures. This is owing to issues related to definition of osteoporosis, especially related to the falls and the fractures that develop from the falls. Diagnosis secondary, and the diagnosis secondary to the systemic nature of the osteoporosis. So screening of osteoporosis has been updated. And we appreciate the screening, especially done by the healthcare providers, that can implement effective intervention before the fracture occurs and ultimately improve the quality of life, as well as help to curb the looming osteoporosis-related costs, which is definitely an expensive disease. The burden of high fracture probability increases with, been increasing with the with several parameters, especially related to the timing. So the number of individuals in millions, and this is a worldwide values of incidence of developing fractures related to the risk with FRAC scoring, without even doing a BMD in these individuals from 2010 to 2040. And as you can appreciate it, every calendar year here has been mentioned in terms of millions of people who are at risk for developing major osteoporotic fracture increases significantly. So whatever the tool we want to use, we want it to be sensitive, also specific, so we can help patients to preventing from developing complications. The incidence of hip fractures in the Gulf countries started with the National Registry in Kuwait that was published in 2015, describing in men and women the hip fractures per 100,000 hip fractures in Kuwaiti population above the age of 50. That was from the time from 2009 to 2012. And in men and women, both of them noted a slight increase in the incidence of hip fractures from 2009 to 2012, 147.8 for every 100,000 hip fractures. And it goes well within the moderate range between, if you compare it to regional and more international incidence for fractures, in Kuwait would be somewhere in the moderate range. Very recently, Qatar has also published its incidence for hip fractures developing to the FRAC scoring. Similar range in terms of hip fracture incidence per 100,000 population, whether we're looking for the years from 2017 up to 2019, with the range of 112 up to 129 per 100,000 population. And as mentioned in the incidence in Qatar, the value was comparable to those in the regional, but less compared to North America and European countries. Also, more recently, the Saudi also has published its own incidence hip fractures in Saudi Arabia, and compared that also to other hip fractures in the Gulf region, in Kuwait, and specifically Abu Dhabi, that was also published somewhere around 2015 or 16. Looking at the annual incidence of hip fractures in men and women, those three lines, Kuwait, Abu Dhabi, and Saudi Arabia, they look similar. They slide in men at the early age between the ages of 40 and 60. There's slight differences, but in between the ages of 60 to 90, they are quite similar in terms of the annual incidence. And women is a little more tightly similar fashion in terms of the incidence rate. Slight differences in the beginning where the Kuwait model or the Kuwait incidence scores a slightly higher incidence in men and women, but later on they're very comparable. So that gives us an idea about the probably incidence hip fracture in the Gulf region. They're pretty much very equal among each other. So the screening helps to identify the patients with the highest need for osteoporosis therapy, which is crucial to reduce the hip fractures. But who should we screen for? So the timing for osteoporosis diagnosis supposedly starts at the screening period. And in screening period, we use some items to help us to identify the patients with the highest risk for fractures, especially age. So aging is a most important value to predict the osteoporosis. Family history for hip fractures, drugs like steroids, for example, lifestyle like related to caffeine intake, calcium and vitamin D, and medical conditions like chronic inflammatory conditions, and even type 2 diabetes. They are very common causes for increased risk for fractures, and that's the optimal timing of diagnosis. Another way of diagnosing osteoporosis is a fragility fracture. Unfortunately, that would be too late to prevent developing complications. And we want to catch patients when they are in the screening period before they develop into fractures. And we want to do that more intensively because as we can see here, the risk for a second major osteoporotic fracture after the first one becomes very high. This is a diagram from Dr. Kenneth's group looking at the risk for the first major osteoporotic fracture in the whole population. This would be the risk in the whole population, and this is the time with years. But in patients who would have a first osteoporotic fracture, and then the risk for developing a second osteoporotic fracture is much higher. It's 3 or 4 folds higher than for the whole population as a first osteoporotic fracture. The risk becomes much higher, or actually is higher in the first 2 years after the first osteoporotic fracture. Then it plateaus, and even after it plateaus, still the risk for a second fracture is much higher than the risk for the first fracture. So that tells us that those patients who already develop as a secondary prevention, we want to prevent a secondary fracture, the risk is still elevated, and we want to prevent the occurrence of the first fracture from the beginning. And this is based on the model of a patient who's a woman at the age of 75 years. And we have to appreciate that because there's still, even though with the high risk for fracture, there is a lot of gap in initiating therapy. This is a new publication from Europe looking at the average treatment gap between the time of diagnosing osteoporosis and the time of starting osteoporotic therapy. And these are from different regions in Europe, and they were divided based on the treatment gap, whether it's moderate treatment gap, high, or very high. So 60% here, for example, means that that's the percentage of patients who are diagnosed with osteoporosis never receive therapy. There are less than 60%, then you have a 60 to 75, and more than 75% is considered as to be very high. On an average in all these countries is about 71%. That gives them about 15 million out of 21 million women needing intervention and left untreated. So this is very important, not only to screen, but to try to identify the patient at the highest risk for developing fracture and start to introduce therapy very soon within the diagnosis. So screening for osteoporosis, we can summarize it as that. All patients who sustain a fragility fracture, they require a BMD evaluation and therapy at the same time. The BMD works as a baseline rather than a diagnosis. All patients with increased risk for fracture, they require BMD evaluation, then therapy if the risk is elevated, and probably here the need for reusing one of the calculators to appreciate the risk. You can consider an imaging for vertebral fracture. That's also another way for screening for osteoporosis, especially in patients with acute back pain, with risk factors of osteoporosis, or even asymptomatic individuals with significant other risk factors for vertebral fractures. So this is one part of diagnosing osteoporosis. All patients with a low risk for fractures, they do not require a BMD evaluation and they can be reassured. Still, they need to be reevaluated for bone density or even risk for fractures every now and then. So the WHO criteria for diagnosing osteoporosis depended on standard deviations, which are known as a T-score or even a Z-score. So these standard deviations kind of predict the risk for developing fractures. So standard deviation minus 2.5 and less predict the risk of fracture higher, and that's what define the presence of osteoporosis. But the problem is that BMD or T-scores itself, they are not really enough. Like BMD as a density can predict the increased risk for fractures that is comparable across populations, but the absolute risk of hip fracture specifically can vary between countries up to 20-fold. And we've seen that when I presented the incidence of hip fractures, and we said that in the Gulf is different from what's in the North Europe and also in North America and also in Europe. So BMD alone has a suboptimal sensitivity and specificity, and the ability to predict fracture risk is improved when the BMD is combined with clinical risk factors, and that's what the clinical risk factor scoring actually can help with. Also, if you use the T-score model or the WHO model to diagnose osteoporosis, and you look at the number of fractures in patients, you will see that the highest number of fractures happens in the population who have defined as osteopenia, even though still the fracture rate is much higher in patients with a lower density, means lower T-scores, but the number of fractures is still higher in patients with osteopenia. Why? Because we still have a lot of population on the osteopenia range more than in the osteoporosis range. So those patients specifically need a better tool to predict the risk of fractures, and we can start them treatment relatively early. So one of those calculators or ways to predict the fracture is the use of frac scoring. And I'm sure a lot of audience here has been exposed, used, or known about the FRAX tool. Now, the FRAX tool is basically developed by the WHO and University of Sheffield. It's a country model, so you have to log in the country that the patient is originated from to appreciate the risk for fractures for that patient. There are several questions that need to be answered. Some of them needs further explanation, like previous fracture, which occurs in the adult life spontaneously or after minor trauma, steroid use, which is usually glucocorticoids that's 5 milligrams or higher for about 3 months. Rheumatoid arthritis or even type 2 diabetes would be equivalent to this risk. And also secondary osteoporosis that's been looked at in the previous trials developing into the FRAX tool, which are type 1 diabetes, osteogenesis imperfecta in adults, untreated long-term or long-standing hypothyroidism, hypogonadism, premature menopause, chronic malnutrition, malabsorption, and chronic liver disease. Identifying these parameters or clinical risk factors with the addition also of a BMD, which is number 12 here, which is an optional way of predicting risk for fracture. That adds into identifying patients with the highest risk. And as we mentioned before, the 10-year risk for probability of an osteoporotic fracture in a female patient who's 65 years old with a T-score of minus 2.5 with a BMI 25 is very different between the groups of the origin of the patient. So patients from the Gulf region, their risk for fracture in that scenario would be somewhere between 6 to 7% in the major osteoporotic fracture. That's different if you look at population from Northern Europe, for example, like UK, Austria, or Switzerland, or even from North America. Those risks is actually much higher. So minus 2.5 could be an appropriate level of starting therapy because the risk is very high in that scoring. But with that T-scoring, the risk is much lower in the GCC population. That's why T-scores by itself, without predicting the risk for fracture, it's very difficult to use it as a parameter for therapy. We have to know, and I recommend you to look up this publication, recent publication from last year. This is from the NOG, or the osteoporosis group of the UK, looking for adjustment probability of a FRAX. So FRAX, to have a proper FRAX scoring, there is some adjustment that needs to be done. For example, there is certain adjustment needs to be done for steroid dose, for discordance between the spine and the hip, for TPS. If it's available at your site, you can use TPS as a way of improving the prediction of a fracture, which is, we call it trabecular bone scoring, tells about the pixel density of the spine. The hip axis length, not been used, practiced that often. Fall history, you can actually, patients with repeated fall history, you can increase the risk by 30% of the scoring of the final scoring. The country of birth, you have to use the country of birth when you're using FRAX model. Type 2 diabetes, you can click yes when in the input of rheumatoid arthritis. Recent or major osteoporotic fracture, there's also a way of increasing the risk for fracture based on the recency of the present falls of the patient. So understanding there are certain limitations of this FRAX, and maybe this can be altered by using these adjustments of probability. So this adjustment of probability, or even the FRAX scoring, comes in identifying patients with the highest risk for fracture. So the initial data we published in Kuwait with the K-industry group from 2018, looking at the FRAX scoring in Kuwait, where we looked at the hip risk, at the risk for hip fractures, or the incidence of hip fractures, and we predict from that a model to predict the risk for fracture. So we use certain terminology as a lower assessment threshold, which is the 10-year probability of a major osteoporotic fracture in someone, or a woman, sorry, who has no risk factors. And we decided that, or it was decided that when the risk of a fracture based on the age model is below the lower assessment threshold, that means those patients do not require to be on treatment. Whereas if they actually score above the upper assessment threshold, which is 20% higher than the risk of someone had a previous fragility fracture, that means the risk is considerably high and those patients need to be on therapy. If they scored between the upper and the lower assessment threshold, then those patients, we need to reevaluate their risk of fracture by doing a DEXA scan. And when we measure BMD, we look at the risk again by looking at the FRAX scoring, and then come up with a value, whether it's above the intervention threshold or below the intervention threshold. The intervention threshold is actually probability of a major osteoporotic fracture of someone with a previous prior of a fracture. This has also been adopted with several other guidelines. 2018, also in the European guidelines, have used the same model, age model, where they use lower assessment threshold, upper assessment threshold, and also intervention threshold in patients who measure their BMD. After that, the country model for GCC has been announced that they are part of the FRAX model now. Kuwait 2015, Abu Dhabi 2017, Qatar 2021, and Saudi Arabia also recently 2021. Recently also, a couple of years ago, there was published the GCC consensus in the diagnosis and management of osteoporosis in postmenopausal women. And in that guidelines in the GCC, there were 3 ways of diagnosing osteoporosis. One of them is using the FRAX as a country model, and if the risk increases above the upper assessment threshold or above the intervention threshold when the BMD is measured, then these patients require to be on therapy. But also adopted within the guidelines the use of T-score of less than -2, because 2.5, because there are some country models not available in the Gulf. Plus, there are some expatriates living in the Gulf which do not have a specific FRAX model or even intervention threshold that's been defined. So it's appropriate to use T-score in that population. And definitely with every guidelines, if there is any presence of a fragility fracture, that's an indication for treatment and a diagnosis for osteoporosis. Similar to what's been described, lower assessment threshold, this is from the GC consensus, lower assessment threshold, upper assessment threshold. These are 2 lines that indicate a lower risk without therapy, a higher risk with a required therapy and then intervention threshold, which actually divides the patients after using a BMD, whether they need to be on a therapy if they're above the intervention threshold or do not require therapy if they're below the intervention threshold. A newer development for the FRAX models has been identified and been described in the UK guidelines related to the osteoporosis screening, also been adopted by the NICE guidelines, which is the looking for the patients at very high risk threshold. And these patients in the high risk, they have been divided to two groups, the very high risk and the high risk. The very high risk is actually 60% higher risk developed compared to the intervention threshold, whereas the upper assessment threshold is 20% higher in terms of compared to the intervention threshold. The reason why is you want to identify the patients at the highest risk for developing fracture, because these patients would benefit from starting anabolic therapy compared to the high-risk individuals, which can start anabolic versus anti-resorptive therapies. Another thing, in the NOD guidelines in the UK, they also adapted what we call a dual or combined dependent pathways, which is using an age model and a fixed model, where they looked at the age model, increasing the risk with the age up to the age of 70, and after the age of 70, they adopted 10% or about 20% risk, which is a specific risk based on the after the age of 70. Indication also for screening is, and also identifying patients at risk for treatment, is identifying vertebral fractures. And this has been mentioned in several guidelines to screen for vertebral fractures, either by VFA, or which is vertebral fracture assessment, which is evaluation of the vertebrae by doing a DEXA scan or doing just a regular X-ray in the lateral thoracic and lumbar spine. This is part of what we mentioned in the Kuwait osteoporosis guidelines, unpublished data, a summary of recommendation that's put on the website from 2022, that we recommended all aged women above the age of 70 and men above the age of 80 to screen for vertebral fractures, even though they could be asymptomatic, just because the risk for having hidden a spine fracture above these ages are common. Plus, in men and women above the age of 50 who have risk factors like low trauma fractures, histological height loss of about 4 centimeters, or prospectively 2 centimeter height loss, or recent or ongoing steroid therapy, these patients are increased risk for hidden or asymptomatic vertebral fractures, and we want to screen for them. These are examples for two devices, the GE and the Hologic, looking for these hidden fractures in the VFA, which is the vertebral fracture assessment, looking at the whole spine visual evaluation to evaluate for presence of fractures. You can see T12 here in this GE, and you can see here in the L1 or L2 in the Hologic. Trabecular bone score, we mentioned that briefly. It's a texture parameter that we can evaluate the pixel grain level variation, and then the DEXA scan that's also only done in the spine. If you have a dense bone, which is a healthy bone, those pixel variations will be more, and the amplitude of these pixels will be less. When you have a porous bone or osteoporotic bone, the pixel variation will be less and the amplitude will be higher. We'll show to you that in the next slide. TBS can give an indirect way of trabecular architecture. So it's more of a quality of the bone rather than quantity or density of the bone. When you have a TBS to be low, that suggests a worse prognosis, a worse bone structure. This is a TBS, for example. This is a healthy bone. If you look at the spine, it's a very healthy spine. You will see the variations, the pixel, the variation is large, meaning you don't see similar colors adjacent to each other, and you see the amplitude is actually low. You don't see dense colors, and the variations are wide, meaning there's no close to each other colors. When you have a porous bone, an osteoporotic bone with microfractures, you will see that the amplitude is very high and the variations is less, meaning there are a lot of areas which are close to each other, covered by the porous bones, and this amplitude is much higher. This bone scores less in TBS, and the healthy bone scores higher in the TBS. So the approach for management in patients who have osteoporosis comes in two divisions. First, we have to identify the patients at the highest risk for fracture, because these patients at the highest risk for fractures, these patients would benefit from starting a bone-forming agent for about 1 to 2 years. And this could be a teriparatide or a paloperitide, which is a PTH-dependent bone-forming agent for 2 years, or romosozumab for 1 year, or sclerostin inhibitor. This is followed by, after inquiring the density, by an anti-resorptive agent for about 5 to 10 years or even longer, depending on which therapy you're using, either bisphosphonate or denosumab. The question comes when to stop, and this is still debatable. I'm not going to really go deep into that, but it's really well debatable on how long you want to treat the therapy for osteoporosis. So this comes from the GCC consensus about the use of therapies. Raloxifene can be a good therapy for patients who are young, postmenopausal women with vertebral fractures or risk for vertebral osteoporosis. Oral bisphosphonates, generally, they are a first-line therapy in majority of men and women with osteoporosis. Teriparatide, also considered as a first-line therapy in patients with severe osteoporosis or even with spine fractures. Denosumab also could work as a steroid-dependent, as a first line for steroid-induced osteoporosis, but also can be used as a first-line agent also in patients with osteoporosis, whether men and women. A sclerostin inhibitor, I want to touch base on this therapy. It's a new therapy been using in the Gulf. Some countries have more experience than the others. Sclerostin inhibitors is a new group of therapies that used to treat osteoporosis. There are several sclerostin inhibitors under development. The one that is actually in the market right now is romosozumab. It's a humanized monoclonal antibody. One is still in the big under development is blosozumab, similarly monoclonal antibody, and there is one molecule still undergoing investigations. So the idea of sclerostin inhibitor or romosozumab specifically, that is a monoclonal antibody, binds and inhibits sclerostin. Sclerostin is actually a molecule that's produced from the osteocytes, and this is the first time that actually we're dealing with a molecule for therapeutic cause with a therapy or actually a molecule that's actually produced from the osteocytes. All the therapies that's been used with an anabolic or anti-resorptive, they work also directly on osteoclast or osteoblast, but sclerostin is produced from the osteocyte cell. This romosozumab, for example, inhibits the sclerostin molecule. And by inhibiting sclerostin, we can stop the inhibiting the osteoblast differentiation. Also, we can stimulate the right ligand expression that can help with the inhibition of osteoclastic activity. The romosozumab and all these monoclonal antibodies, when they inhibit sclerostin, they have a dual effect where they can actually increase bone formation. At the same time, they can decrease bone resorption. And they can do that simultaneously at the same time. Now, it's a subcutaneous injection given monthly basis, with anabolic therapy wanes off after 12 months. Where it's left only is the anti-resorptive effect. So, in terms of therapeutic use, it's not used beyond the 12 months just because the anabolic effect fails after or plateaus after that and wanes off. So we don't use it beyond the 12 months, and we have to stick to this kind of therapy in that way. Similar to what we use with other anabolic agents, that after the 12 months, we have to follow it with anti-resorptive to continue the therapy. Romosozumab came from several trials to show the effect. This is the one of the trials, where they randomized patients, postmenopausal women, to use romosozumab versus alendronate versus teriparatide. And here they were looking at the lumbar spine density and the total hip density, not a fracture yet. And they were seeing that the romosozumab, given at the monthly injection, the level of BMD increase in the lumbar spine is actually much higher than what the teriparatide could do, and also what the alendronate can do. And this is seen in the lumbar spine and also in the total hip, though much higher from the current therapy in terms of increase in bone density. In the FRAME study, also looked at the incidence of new vertebral fractures after 12 months of therapy, where they randomized patients for romosozumab and versus placebo in blue. So the risk was about almost 73% reduction in the incidence of vertebral fractures. After 1 year of therapy, both groups, whether they're receiving placebo versus receiving romosozumab, both of them were put on denosumab. And the denosumab, they continued for an additional year. So that's 2 years now total of therapy. And the difference between the two groups is still about the same, about 75% reduction in terms of risk of developing new vertebral fractures. In this trial, the FRAME trial, they looked at the side effects. They were well balanced in majority of side effects, including hyperostosis, cardiovascular events, osteoarthritis. There were more injection site reactions with the romosozumab compared to placebo. There was 1 atypical femoral fractures and 2 cases of osteonecrosis of the jaw were observed in the romo group. The other trial was the ARCH trial, and the ARCH trial was actually comparable against a competitor. Here was comparing romosozumab versus alendronate for, again, one year, so 12 months, showing a significant reduction in the incidence of a primary outcome, which is the new vertebral fractures, for about 37% reduction. And after the first year, both of these groups were put on alendronate. So patients on alendronate continued on, and patients on romosozumab, they were put on alendronate. For additional 1 more year of therapy, still significant risk reduction in the incidence of vertebral fractures, about almost 50% reduction. In the second trial, which is the second trial, we looked at that there was an imbalance in terms of the cardiovascular adverse events. 2.5% in the romo group versus 1.9% in the alendronate group at 12 months. That was not seen in the previous presented trial, which is the FRAME trial, which was actually a much larger group of patients of more than 7,000, which was a placebo versus romosozumab. So we're still not really clear about why there was an increased cardiovascular events. It could be the alendronate might be decreases actually the cardiovascular events, and that's maybe what tilted the romosozumab to have the higher risk. But anyway, there is for the use, there is not been used for or should not be initiated in patients who have had MI or stroke within the preceding year, and in patients who do not have cardiovascular events, you need to consider whether the benefit outweighs the risk in patients with multiple risk factors for cardiovascular disease. And this comes from the FDA also as a way for starting therapy. The last part here, just describing the follow-up, and this comes from the GCC consensus. So in terms of follow-up of patients with osteoporosis, you want to assess the compliance and the side effects of patients of the therapy. If you have a luxury to do bone turnover markers, you can use that to verify the compliance. You can do it after 3 to 6 months after starting therapy. You want to consider continuing or stopping therapy. If you're doing 3 years of IV bisphosphonates or you're doing 5 years of oral bisphosphonates, you can consider patients giving them drug holiday. But that's only if the patient has a low risk for fractures, meaning he has not fractured anymore. He's been doing well increasing bone density. He is not on a therapy to cause a decline in the bone density. But the patients with the high risk, which is completely the opposite of what I mentioned, those patients probably they continue the treatment for a longer period of time or even switch therapy to a different molecule if it's required. Denosumab, we still do not have a clue when it's safe to stop. We want to continue as much as possible. If there is any good reason to stop denosumab, then most likely these patients need to be switched to a different therapy like bisphosphonates, for example, to continue for a longer period of time. So in conclusion, identifying patients with the highest risk for fracture is crucial to lower the osteoporosis complications, especially with prior fragility fracture. Risk-based guidelines for screening and diagnosis of osteoporosis improve the selection of patients at the higher fracture risk for therapy, and adopting fragility fracture calculation method and local guidelines is advised to optimize delivery of medical management. So with that, I end my presentation. Thank you so much for your attention.
Thank you very much, Dr. Thamer. Really very clear and right to the point presentation. We have already some questions that we'll probably address at the end of the session. We'll have plenty of time to answer the questions of that are really relevant to the presentation. Now, to continue with the same trend, it's my pleasure to introduce the second speaker. The second speaker is Dr. Youssef As-Saleh. Dr. Youssef is a professor of medicine and endocrinology at King Saud bin Abdul Aziz University for Health Sciences. He's the ex-president of GATE, which used to be the AIDS Gulf chapter. He was president between 2019 2020. He's the vice president of the Saudi Osteoporosis Society in 2015. He's the past president of the Saudi Board of Medicine 2010 and 2016. He has published more than 50 publications. He's always very active, right on when it comes really to academic and teaching activities, and he's a member of several national and international committee and organization. So it's a great pleasure for me to introduce Professor Yusuf Saleh to address the issue diabetes and osteoporosis.
Thank you very much, Dr. Ali. Pleasure and honor to be with you tonight. And I do thank Wiam Hussein for inviting me. And good to get in touch with dear colleagues, Ali and Thamer and all others who are attending this presentation. So my task is to talk about osteoporosis and diabetes. I thought when Wiam sent me a message to take care of this topic, that's going to be an easier job than talking about guidelines that Thamer did very well. But I realized later on that it's not really easy task to do, and it's a complicated sort of presentation. So I'm going to try to make it as simple as possible. If I'm able to open my presentation, then I'll start immediately. And I have no disclosures related to this presentation. Says file repair. It was open a while ago, so I'm not sorry for this technical issue regarding opening the presentation. So diabetes is so common, and also osteoporosis is two common diseases, especially in the Gulf region. Apology for that. Okay, here we go. So this is an overview of the subject. This is the outline of my presentation. A few words, slides about the epidemiology of diabetes and osteoporosis in the GCC countries, diabetes and BMD and fracture risk, fracture prediction in type 2 diabetes. Is it different from usual osteoporotic patient? The possible contributing factors for increasing fracture rate in patients with diabetes, the effect of diabetes medications and fractures. What about glycemic control and fracture? Is there any relation? And then pharmacological therapies for osteoporosis and type 2 diabetes. Is it different? Now, osteoporosis in GCC has been reported in several trials in different countries in the region. So in Saudi Arabia, there have been a systematic review that included 7 studies, 5,160 patients, and this is in postmenopausal women, and the prevalence was 34% in women between 50 and 80 years of age, while in men, this is based on 3 studies that included more than 800 men, the prevalence was 30.7. In Bahrain, there was a retrospective study that was published in 2020, not far away, by Sadat Ali and another colleague from Bahrain, I think May Matar, a retrospective study from 5 randomly selected primary healthcare centers in Bahrain, and the prevalence among 170 postmenopausal women was 27.1%. The Kuwait studies, when I looked at them, I'm not sure if this is the most recent. However, I found a cross-sectional study for females population from Hawali province, one of the large provinces of Kuwait state. In 454 postmenopausal Kuwaiti females, 20% had osteoporosis of the spine and 12.5 at osteoporosis of the femoral neck. So there have been some variations in the prevalence of osteoporosis in various GCC countries. I did not include other GCC countries just for the sake of time. Now, if you look at regional studies looking at the association between osteoporosis and diabetes, the only study that has been cited in the literature was done by Mohammed Al-Ma'toug and his colleagues from King Saud University in Riyadh, where he found that in 104 postmenopausal females compared to 101 control postmenopausal females, spine bone mineral density was lower. So if you look at spine standard deviation in diabetics, minus 2.28 compared to minus 1.2. And osteoporosis was present in 46.8% in diabetic postmenopausal females compared to 22.5 in control postmenopausal women. And this is in the spine. In the neck of femur, again, the same observation was there, that diabetic females had a lower or high percentage of osteoporotic patient, 19.8 compared to 12.1. And this confirms what international studies has found, that osteoporosis probably is more common in diabetics, especially type 1. Now, looking at type 1 diabetes, now I'm going to divide the talk and the coming few slides into type 1 and type 2. So in type 1 diabetes, these patients, they have reduction in bone mineral density. However, compared to the magnitude of reduction in density, the fracture incidence is much higher than what is expected from that reduction in BMD. So if you look at the spine, this is Vestergaard in 2007, spine Z-score, these are young people because they are type 1, minus 0.22. The expected relative risk of fracture based on this is supposed to be 1.09, while in reality, the actual relative risk was much higher, 2.88, and that's statistically significant. The same observation was found at the hip, but even more pronounced. So in type 1 diabetes, the density is decreased a little bit, but the fracture incidence is much higher than what it should be with that reduction in densitometry readings. Fracture rates is higher, and this is looking at all of these studies, probably 9 or 10, including more than 27,000 subjects, and the increment in fracture rate in diabetics is overwhelming if you talk about evidence. So truly, type 1 diabetics, they have much higher rates of fractures. And the relative risk, again, looking at this meta-analysis of these studies by Shah in 2015, relative risk of hip fractures 3.8, while vertebral fractures 2.9, and that's statistically significant compared to non-diabetic population of the same age without type 1. These patients, they have reduction, lifelong reduction or years of reduction in insulin level. And we know that insulin is an anabolic hormone that stimulates the growth of various tissues, including bone cells. And the reduction in insulin has a lot of effects to decrease with the reduction in IGF-1 on bone surface area, bone size, the height of these people, their body weight, and all of these, in addition to the endothelial and vascular changes that happen in the bone with the reduction of insulin, that results that these patients with type 1 diabetes have reduction in density and increased rates of fractures. It's, however, looking at the bone markers, and I'm going to show another slide related to the bone markers in patients with type 1 diabetes, all the markers of resorption and formation are reduced. So it's not only reduction of anabolic action of insulin, but also resorption is also reduced, as evidenced by reduction in CTX, B1MB, and osteocalcin. CTX is a resorption marker. P1MB and osteocalcin are formation marker, and lower IGF-1. So their various studies has documented this finding that there is probably a low bone turnover overall in patients with type 1 diabetes. So the reduction in bone turnover has a lot of pathophysiological backgrounds, probably there is also some slight increment in bone resorption, but overall, type 1 diabetes is a low turnover status. So in summary, these patients with type 1, they have lower BMD, but increased fracture rate, which is greater than predicted by the magnitude of reduction in bone mineral density. Likely low bone turnover, impaired formation, the microvascular disease that happen in these patients may contribute to bone loss. We'll talk about the relation between complications of diabetes and the risk of fractures. While looking at type 2 diabetes, it's the opposite. These patients have higher bone mineral density, and mainly because type 1 patients are overweight or majority of them are obese. The biological effect on DIXA artifact as well, because abdominal obesity when measuring spine DIXA might affect the reading. The anabolic effect of hyperinsulinemia for years related to insulin resistance, or the use of insulin injection later on to control blood sugar, make these patients having normal or high bone mineral density. But even though the expected relative risk with reduction in Z-score, for example, in some patients in this study, the expected relative risk of fractures is 1.2, while in reality, we see more fractures in patients with type 2 than predicted by the normal or higher BMD than normal subjects. The hip fracture rate, so fractures are also increased in type 2 diabetes, but the magnitude of increment is lower than what we see in patients with type 1. The relative risk is 1.7 for hip fractures, and the relative risk for any fracture is 1.2. Vertebral fractures are probably not as worse in patients with type 2 diabetes as to hip fractures, so they tend to have more risk of hip fractures, but both types of fractures are increased in patients with type 2 diabetes. In the Iowa Health Study, I selected this study because it included a huge number of patients. So this was a prospective follow-up patient of 41,000 subjects, postmenopausal women that started back in 1985. Patients were followed for 12 years. And there was a questionnaire sent to them about diseases and risk factors, especially for osteoporosis and fractures. And what the study found that in type 1 diabetes, the hip fracture is 12.25, and in type 1, 1.7. I'm sorry, I mentioned earlier that type 2, but actually in reality, type 1 diabetes, they have more rates of hip fractures than vertebral fractures. Now a question comes to our mind. Can we use the bone mineral density T-score or FRAX to predict fracture in type 2 diabetes? We don't do much of these in patients with type 1 diabetes. They are young people, and we tend not to have much of studies of BMD, the usual pattern of BMD loss in patients with type 1 diabetes compared to type 2. So looking at 3 big studies related to type 2 diabetes and osteoporosis, and the study of osteoporotic fracture, Mr. Os, and Health ABC, and the study of osteoporotic fracture in women, non-diabetic, 7,000 subjects, 500 in diabetes. The average age was 73. Mr. Os was a study in men, comparing 5,000 normals to 800 diabetic men, and Health ABC included women and men, a relatively young and smaller number of studies, 1,200, 1,100, and 250 diabetic women, 300 diabetic females. And if you look at the finding of these trials, looking at the 10-year hip fracture risk and on the vertical axis, and femoral neck bone mineral density in non-diabetics in this line, the black line, continuous line, and looking at diabetics with no insulin and patient with insulin at any rate of femoral neck BMD, diabetics with patients on insulin are having higher rates of fracture, and this happens at more magnitude in women compared to men. So they tend to have more 10-year hip fracture risk compared to control. And this has been documented in these trials. And this tells us that yes, FRAX and the 10-year hip fracture risk using FRAX predict patients' hip fracture rates or risk in patients with diabetes, especially, and it's found that it's in men, patients on insulin, they have higher rates of fracture, while that does not happen in women. So in women, the increment compared to control of increment and 10-year hip fracture probability is the same whether the women are using insulin or not using insulin. Now, coming back to the question, does it predict the risk? And in fact, this is a big study, a landmark, a Canadian study, and Manitoba, Canada, where they looked at this and the Kaplan-Meier curves of this study. So it's has found that patients, the 10-year survival, fracture-free survival in diabetics is much lower than patients without diabetes. Now, what is the expected is depicted on this graphs. So in this graph comparing diabetic to non-diabetics, what is expected is overlapping with patients without diabetes, while what is observed that patients with diabetes are having a higher rate in reality than what has been predicted by FRAX method. So the answer to this question that I just mentioned, that FRAX, yes, it's valuable. It tells us the probability of fractures, the 10-year probability, but it underestimates the risk on diabetics. So comparing what is expected and what is observed from FRAX and what is observed in reality, patients with diabetics in the upper curve are having higher rates of fracture. So to summarize this, BMD T-score and FRAX predict, but it underestimates the fracture risk in type 2 diabetes. And there have been a lot of talk requesting adding type 2 diabetes to the FRAX algorithm. That didn't happen till now, but there have been a strong suggestion by experts to use some sort of adjustment. And the adjustment that has been suggested are 4 suggestions using rheumatoid arthritis. So when you do FRAX, click on rheumatoid arthritis as a proxy for the effect of diabetes. TBS adjustments. So you do TBS if you have that software in your DEXA scanning, and the TBS adjustment will make the predictability of FRAX much better. And then the reducing the femoral neck T-score by 0.5. So when you enter the T-score writing, check the patient T-score on the DEXA and lower that by 0.5, enter it, and then calculate the FRAX. The other thing is to increase the age input by 10 years. And these are the suggestions that has been raised actually by experts that included John Canis, the father of FRAX in the world, Eugene McCloskey, and Helena Johansson, and others in the WHO. So we are yet to see diabetes as one of the 9 or 10 risk factors that are included in the FRAX. I think in the near future, we're going to see it included. But till that happens, you can choose any of these 4. And by the way, there is no methodology which is better than the other. So there is no study that compared if rheumatoid arthritis as a proxy compared to the increasing age by 10 years will predict fractures in diabetics better than the other methodology or the other method. Now, why patients with diabetes are having these complications with fractures despite that their BMD is normal or increased, talking about type 2 diabetes. The glycation of proteins that happens in patients with diabetes, and as we know that this glycation increases the rates of complications, the vascular complications that we all know about, whether on the kidney, the heart, peripheral blood vessels, and so on. The same thing happens in bone. So advanced glycation end products that modify protein in the bone affect bone matrix, affect mineralization, osteoid formation, and modify the collagen content of the bone. There is impairment in the secretion of various cytokines and insulin-like growth factors. So in tissue studies of bone patients, biopsies taken from patients who patients with diabetes or fracture, and looking at the electron microscopy, what happens to them, lots of changes in the collagen tissue of these patients. And there have been markers of or measurement of urine samples of these patients, looking at advanced glycation end products. And they found that these end products are increased in these patients. And the biopsy of the bone of these patients have documented a lot of changes in the physiology, the morphological parts in the bone, and increase in certain cytokines, looking at the analysis of various proteins in the bone, where interleukin-6, interleukin-1, tumor necrosis factor alpha, all of these cytotoxic cytokines are increased with reduction in the IGF-1. There is the effect of sarcopenia, alteration in the activities of collagen and bone cells, and sarcopenia is more common in patients with diabetes, so muscle function happens and weakness happens. The bone turnover is reduced, the mineralization service is reduced. You can look here at type 2 patients compared to control, and you can see the reduction in mineralization service and bone biopsy. Osteoid surface is markedly reduced, and osteoblast surface is reduced. So overall, lots of reduction in bone quality rather than density in patients with type 2 diabetes that makes them more vulnerable to fractures. Now, coming back to the slide that I mentioned earlier, there have been a lot of studies looking at bone markers, and all in all, the reduction in various markers, anabolic or formation markers and resorption markers, is the landmark of patients with diabetes that has been found. So there is increment in sclerostin, and that's why our colleague who talked about a while ago about Thamer talked about the anti-sclerostin antibodies. So sclerostin inhibits bone formation, and it has been found to be increased in patients with diabetes. Bone resorption markers, CTX is reduced in type 2, and in patients also with pre-diabetes and insulin resistance, reduced or neutral. But the majority of the studies, there was reduction in resorption markers like CTX, tartrate resistant acid phosphatase, NTX, and also in formation markers. So you get reduction in P1MP formation marker, bone specific alkaline phosphatase, and osteoprotegerine is increased. And osteoprotegerine is the protein that inhibits the rank attachment to its ligand on the surface osteoclast. And if you increase that, you allow rank to get attached to rank ligand and activate osteoclast and get them more mature. There have been also at the cellular level changes in the Vent beta-catenin system, the signaling pathway, which experts know about, and this promotes osteogenesis. And the paroxysm, there is a shift from activation of the Vent beta-catenin segment of the pathway to more activation of the B-bar gamma pathway. B-bar gamma activation promotes adipogenesis rather than activation of anabolic effect or osteoblast function in the bone. There's been studies that looked at the alteration in the transcription of osteoblast promoting genes, in particular this gene called RANX2. There is increased, as I mentioned, in interleukin-1, 6, and TNF alpha. And we talked about sclerostin, the increment in sclerostin that makes the bone formation reduce in patients with diabetes. So this is, again, talking about the same thing, the changes in rank ligand. And all of all, these effects result in reduction in the bone quality. So again, to stress the point, density is not changed in diabetics, but bone quality, there have been studies documenting huge changes in the bone quality of patients with diabetes, whether type 2 or type 1. Now, looking at the complication of diabetes, neuropathy, retinopathy, hypoglycemia, and sarcopenia. So neuropathy will make patients have a lot of imbalance, make them predisposed to fall. Retinopathy and decreased vision, we know this is a strong risk factor for falls. And even if you're osteoporotic, if you don't fall down, you don't fracture. Hypoglycemia predispose them to fall and fractures. And sarcopenia and weakness in the muscles will make them again fragile. And all of these play a factor a major role in increasing fracture rates in patients with diabetes. This is studies looking at Finland study, Rotterdam, St. Louis, Enhance, study of osteoporotic fractures, and all of them documented increment in the rates of fractures in patients with type 2 diabetes. Trabecular bone score, this has been mentioned by our colleague earlier on, and this will increase the prediction of fractures in patients with diabetes if used with densitometry. So in summary, the increment in fractures possibilities and tendency in patients with diabetes is likely to be due to poor bone quality, and TBS might be useful than BMD for identifying osteoporosis in patients with type 2 diabetes. Now we'll shift gears to talk about drugs, and there have been studies looking at the association of various drugs that we use to treat patients with diabetes to the risk of fractures. And all in all, the only two that we need to get attention to are the TZDs, where TZDs have been found to decrease bone formation, increase adipogenesis in the bone marrow, so increase bone resorption, decrease formation, and reduction in BMD has been documented in studies looking at the TZDs, and fracture rate are increased. Insulin of any increases the bone formation, and so it's an anabolic action, but we don't know if insulin per se has an effect on fracture if you exclude other confounding factors. So it might be only a surrogate. We talked about that study that said that patients on insulin have tendency to have more fractures, but maybe because these patients have advanced disease, more complications, and hypoglycemia with the use of insulin predispose them to falls and fractures. The same thing for sulfonylureas, nothing but much about metformin and sulfonylureas, very conflicting data about them. Overall, there have been no clear reports documenting that metformin or sulfonylureas increase the rates of fractures. TZDs, we talked about them. GLP-1 receptor agonist, in fact, they may improve the effect on density, and we'll mention this in the coming slides. DPP-4 inhibitors, again, they follow the same line of GLP-1 receptor agonist, while SGLT2 inhibitors, there have been some studies that linking canagliflozin to more rates of fractures. However, we need more data about that. So this is TZDs and fracture. Look at the patient on control, not on TZDs, and patient on rosiglitazone, more adipocytes in the bone cells, and that might make them more liable to fractures, and reduction in bone mineral density. And this is looking at histomorphometry, rosiglitazone inducing more porosity in the bone than control. So in patients with on rosiglitazone, probably the rates of fracture is increased, and it is advisable that any patient at high risk of fracture or those who developed fractures not to use these agents for treatment of diabetes, and better to avoid them and go to other medications. However, having said that, in the ADOPT trial, and ADOPT is an intensive use of medications to control blood sugar, there have been patients on bioglitazone and rosiglitazone, and overall, the cumulative incidence of first fracture comparing rosiglitazone, metformin, and glyburide did not differ at all in patients and men, diabetic men, compared to women. So women are having, probably is not shown in the slide, women are at risk, but not men, if they are used rosiglitazone or glitazones overall. We talked about insulin and its effect, and this is something about the SGLT2 inhibitors. Dapagliflozin did not affect bone turnover, and canagliflozin increased bone resorption. The CTX has been found in this study in 2013 that it increases the CTX, and overall, looking at various studies in a meta-analysis So 28 trials that included placebo or comparators, and 20 trials, there are only 32 fractures comparing the drug to placebo, and overall the hazard ratio were not significant for these fractures, for fractures. In conclusion, the control of skeleton is intertwined with diabetes-related factors, fat depot, gut hormones, and pancreas. Potential for negative and positive effect of diabetes treatments on bone. TZDs should be avoided in women at high risk of fractures. Now, glycemic control. I put this slide looking at the glycemic control figures in the Gulf regions, and case A, Kuwait, and various countries in GCC. And overall, our control is not that really good. So it varies. Patients with less than 7% varies between 14 to 35%. Majority of our patients are not controlled, and people have looked at this trying to see if that increases the rate of fractures. So in studies looking at patients with A1C less than 8 and those without above 8%. So patients with poor control are probably tending to have more fractures in the A1C in some of the studies. And in the Rotterdam studies, those below 75 compared to more than 75, those with patients A1C above 75 had more fracture rates. So this is talking about the high A1C. However, also patients with lower A1C had an increased fracture rate. So this patient with less than 6% compared to more increment in A1C, they tend to have higher fracture rate. And many experts say that probably this is related to hypoglycemia and the tendency to have more falls with a reduction in A1C. In the ACCORD trial, and we know ACCORD trial has stopped prematurely, there have been an increment in fractures probably in women. High prevalence of TZD use was in that studies, 92% in the intensive and 58% in standards. However, there was no difference in fracture rate in the ACCORD between the intensive and standard control, but the limitation, TZDs has been used in majority and good percentage of patients in the intensive control, and the comparison was with the standard, not with the poor control patients. The average duration was short, 3.8 years. So intensive control did not affect fracture rate in the ACCORD trial. In conclusion, overall, the relation between hypoglycemia and A1C and blood sugar control and fracture, lower A1C can be achieved in older adults without increase in fracture rate. This is from the ACCORD trial. Observational studies indicate that higher A1C increases fracture risk, but lowering the A1C for several years with high TZDs used did not prevent fracture. This is from the ADOPT trial. Effect of lowering A1C achieved without TZD is not known because this has not been looked at. What about the effect of osteoporosis drugs in patients with diabetes? Is there a difference? Overall, this is in the fracture intervention trial using alendronate. Patients with and red and non-diabetics, you can see the beautiful difference between placebo and patients on alendronate on total hip and lumbar spine, but the same effect happened in diabetics. So in blue, this is a patient with diabetes using alendronate, and they work beautifully in these patients, the same as in diabetics. Raloxifene has been found in observational studies to decrease vertebral fracture rates, as has been shown here. So patients with diabetes, they have marked reduction, but also to a lesser degree, diabetes responded with positive effect reduction in vertebral fractures only using raloxifene in the MORE trial, the multiple outcome of raloxifene effect. Teriparatide has been looked at in diabetes. The lumbar spine increment compared to control is beautiful with teriparatide. The total hip is even better than what happens in the placebo. The femoral neck effect of teriparatide, much better increment in density compared to the placebo using teriparatide, and this is even better. The effect at the hip is better than the spine, and it works also to decrease fractures. The overall non-vertebral fractures has been reduced using teriparatide compared to control. So similar increases in spine and hip BMD, greater increase in femoral neck BMD, and similar incidence of non-vertebral fragility fracture over time. So there was no effect of diabetes to reduce the efficacy of teriparatide in patients with diabetes. Conclusion, alendronate prevents bone loss in type 2 diabetes women, effect on bone material properties and on fracture efficacy not known. Fluoxetine prevents vertebral fracture in type 2 diabetes women. Clinical trial data not analyzed for other therapies. We don't know the effect of denosumab and romosozumab. Type 2 diabetes patients responded to teriparatide treatment with similar increases in lumbar spine and hip BMD and greater increase in femoral neck BMD. I reached the final part of my presentation, looking at various guidelines before I conclude. So there have been comments in the American Diabetes Association Standards of Care for patients with diabetes, the NICE guidelines, the International Diabetes Federation, and many other guidelines, the Canadian guidelines, that advise us to look carefully to the fracture risk in patients with diabetes, improve their nutritional status, improve their vitamin D and calcium intake, make sure that these levels of these minerals and vitamins is good and normal, supplement them if necessary. Try to prevent falls as much as possible in patients with diabetes, especially those on multiple oral hypoglycemic agents and insulin. Try to avoid TZDs in patients with type 2 diabetes, better to avoid them. The effect of TZDs on increasing fracture, lowering the BMD, replacing the bone material with fat is very florid sort of evidence, so better to avoid them. And these guidelines also advise for doing DEXA scanning in a similar fashion like those patients without diabetes. So whenever there is a suspicion, high-risk patients, multiple risk factors, then you go and do a BMD and try to compensate for the presence of diabetes with one of the 4 points that I mentioned, or 4 methods that have been suggested, till we see diabetes as one of the FRAX indices. So in summary, type 1 and type 2 diabetes are associated with higher risk of fracture at the same BMD. So BMD can be misleading in patients with diabetes. Diabetics are at higher risk of fractures. DEXA, BMD, T-score, and FRAX predict fracture, but underestimate the risk. More frequent falls and poorer bone quality contribute to higher fracture risk. And reason for poor bone quality is multifactorial, which lots of effects or reasons that increases the cortical porosity, the increment in advanced glycation end products, the effects or the changes at the cellular levels of patients with diabetes make them prone to bad bone quality and more risk of fracture. Diabetes medication can affect bone. TZDs are very important to look at. Intensive control, as far as we know till this point, does not increase fracture rate, short of having probably severe hypoglycemic attacks. Poor control may increase fracture risk. Limited data on the efficacy and safety of osteoporosis therapy in type 2 diabetes, apart from teriparatide and alendronate. I talked about the things to consider, and I do thank you for your attention.
Thank you very much, Professor Youssef. Actually, if you don't mind getting to speak a little bit closer to your, because at your computer, because really there was some interruption in your voice during the presentation. I tried to alarm you, but really you're so much taken into your presentation that you didn't really listen to my voice. Anyhow, thank you very much for really exhaustive and really right to the point presentation. I think everyone knows really what's the effect of diabetes on bone now by this time. I would like really to open the floor for questions, and I think the audience really that's what they're looking for. There are too many questions. I would like Dr. Thamer to join us. I don't know if he's still with us.
I'm with you.
Yeah, okay, fine. So actually the question, both of you are expert in osteoporosis, and feel free to intervene if the question's been answered. But I would start really by the order, Dr. Thamer and then Dr. Yusuf. Now, some of the questions here with a simple, really practical one. If you're talking about osteoporosis, what is the role of vitamin D, and what is the dose that you advise your patient to be on? So very practical and simple questions. Dr. Thamer?
Yeah, so vitamin D has been looked at in terms of management of osteoporosis. Unfortunately, the results are kind of not going in the same direction. So there's probably confounding factors affecting the vitamin D, since when you're talking about someone who's vitamin D deficient, it's totally different when you're talking about someone who's vitamin D sufficient when doing the management of osteoporosis. So some of the randomized controlled trials have seen some improvement in the density and maybe some even reduction of falls in the skeletal health. So generally, vitamin D is recommended to be used in patients with osteoporosis. The general rule about levels is that levels of vitamin D that is above 75 nanomoles is sufficient. Some guidelines use the cutoff of 50 nanomoles, which is 20 nanograms, which is fair if you're doing well in terms of management for osteoporosis. But I'm going with the guidelines to say more than 75, because what seems from the clinical trials that you're able to suppress PTH better with the higher vitamin D levels.
Okay. Another question maybe for you, and it's basically on management. Does a 55-year-old female patient with T-score minus 2.6 in the spine, hip being normal, need a PRAX score, or should we start treatment immediately? I think there are two questions in one question here.
It's actually very
so
good.
The first one, yes, yeah.
So the question goes is that if a regular DEXA scan was done on a patient, would you start treating based on T-score? So what we've been discussing so far in my lecture is that especially in the GCC countries, T-score can overestimate the risk for fractures in the population of the GCC. Because as I showed in the graph, with a minus 2.5, for example, in a patient, the risk for fracture is much higher if you're from Northern Europe and North America, Europe and North America, compared if you're from the Gulf region. So T-score without calculating the risk for fracture could be misleading. So with any T-scores, I recommend doing a FRAX scoring.
Yeah, and the other point you mentioned, actually, when your FRAX allows you to risk stratify your patient into very high risk versus high risk, and will guide you towards really, as you mentioned, making the proper choice, whether you start with anabolic therapy or with anti-resorptive therapy. Correct me if I'm wrong.
No, you are absolutely right. So this is the benefits of evaluating clinical risk factors with the use of a BMD, that it gives you a better idea of evaluating patients and predicting the risk for fractures and choice of therapy.
Now, again, someone is addressing the question to you specifically. If you in your talk, you mentioned about sclerostin inhibitors, mainly romosozumab. Could you elaborate in its effectiveness when compared to classical osteoporotic management, like the anti-resorptive one, and the major side effect? Actually, that's basically, I'll make it here. What is the indication for the use of romosozumab? And what are the contraindications? Do you look for really the underlying cardiac status of the patient?
So romosozumab is an anabolic agent used as the same criteria as using teriparatide. So we have two anabolic agents we can use. There is only one head-to-head trials between teriparatide versus romosozumab. That's only looking at the BMD values, and romosozumab showed that's actually higher BMD value. The head-to-head trial comparing romosozumab versus other drug therapy for management of osteoporosis comes from the comparing romosozumab versus alendronate, and with the risk of fractures showing better reduction for fracture of romosozumab comparing to alendronate. The duration of use of romosozumab is 12 months, while the duration for use for teriparatide is 24 months. Both of them should be followed by anti-resorptive agents. Side effects of romosozumab usually site injections, similar with teriparatide. Teriparatide, there's a possible way of increasing hypercalcemia. This has been noted in the side and the side effects. That hasn't been clearly seen with romosozumab because it's not really PTH dependent therapy. There's one trial showed an imbalance of cardiovascular events that's only came from the trial with comparing romosozumab versus alendronate. It was not shown in the romosozumab versus placebo. So that gives an idea that maybe alendronate had the effect of lowering the cardiovascular. And there's several actually publication talking about alendronate and reducing calcifications in the vessels. So the FDA says is that if you have a patient with a cardiovascular disease within the last year, that's a contraindication for using romosozumab. If you have a patient with significant risk factors for cardiovascular disease, then it's a basis by so it's a discussion, informed consent with the patients, and overweigh the calculating or knowing the risk and benefits of these therapies.
Okay. Now, can you comment again on the duration of treatment? Yeah, Dr. Yusuf, do you want to comment?
Not on this point, beautifully mentioned by Thamer. Just one thing about a previous question, that the T-score minus 2.6, and I just want to stress what has been mentioned by Thamer, that probably we need to distinguish between T-score as a diagnostic threshold versus intervention threshold. So now there is a position paper that's going to be that is going to come out from IOF that included John Canis as the first author, plus all the others, big, huge, known experts in the field of osteoporosis, Eugene McCloskey and Johnny Bridgester and Cyrus Cooper, the president of IOF, René Rizzoli, all the best Dawson Hughes. So the position paper talks clearly that IOF now is adopting distinguishing T-score as diagnosis versus treatment. So we use it to diagnose osteoporosis, but not to treat. So if you want to treat, do the FRAX, and then, as has been nicely explained and beautifully presented by Thamer, decide if you're going to treat this patient based on the scores and FRAX. BMD is a poor diagnostic test. Remember what have been mentioned by Thamer, that majority of fractures happen in osteopenic, not osteoporotic. And osteopenia, by the way, is not a disease. We should not label patient as having a disease called osteopenia. So this position paper, and I know this as a member of IOF board, is going to come out soon. That says very clearly now by IOF. It was sent for getting the advices from societies on 16th of June, and soon it's going to be published. So no more that you say minus 2.6 treat osteoporosis. You have to look at all risk factors, assess the patient, and then look at the intervention based on the graphs and the figures, and then treat according to that.
That's right. So since you're there, maybe I'll ask you some question related to diabetes. It's on the use of SGLT2 inhibitors and magnesium deficiency. The question here, they mentioned that with SGLT2, there is increased magnesium. Correct me, I think there is decreased magnesium, or am I wrong?
Decreased magnesium. Yeah, decreased magnesium.
That
stimulates parathyroid hormone, by the way.
And there have been, right, and magnesium, low magnesium have been really quite linked really to increase the risk actually of fractures. There have been studies looked into this. Do you want to comment on this really? How do you approach a patient? Do you address all those issues when you have your anti-diabetic medications by maintaining really proper calcium, vitamin D, magnesium level, and so on?
As I mentioned, Ali, diabetics are at more risk of fractures. Probably now, I think we need to take more care of them when we see them in clinics from a bone health point of view. We've been focusing mainly on the diabetes and its complications, making more attention to blood pressure and lipid control and A1C, weight, but totally forgetting about bone health. I think we need to shift our attention to more look at their electrolytes, their bone sort of workup in the labs, and their vitamin D levels and magnesium. If it's low, try to correct it or avoid drugs that lower their magnesium. Honestly, there is no international recommendation on the SGLT2 and magnesium levels. So far, I'm not aware that any sort of ADA or ASD mentioned that you need to measure magnesium in patients who are using SGLT2 inhibitors. If it happens to occur, then you need to treat it based on the fact that you mentioned that probably it affects bone health, increases PTH, and that might increase bone resorption. So better to correct it if you find it.
Okay, excellent. Now, again, one question that really is trying to address the difference between type 1 and type 2 diabetes. You did clearly mention that really DEXA sometimes underscores the risk of fractures, basically in type 1 diabetes, whereas really doesn't seem to do the same in type 2 diabetes. Now, I understand type 1, they have like insulin deficiency, almost complete insulin deficiency, whereas in type 2, there is some have actually high insulin level. Would that be a factor? Do you want to comment on this? Why really we're seeing that disparity, or do you have any other explanation for this?
Yeah, so the lifelong insulin deficiency with lowering of IGF-1 in type 1, they tend to have low BMD, if anything. The Z score is low. While in type 2, mostly adults, you look at the T-score, either normal or even increased because of the hyperinsulinemia. Now, the use of exogenous insulin in patients with type 1 does not really seems to compensate for the endogenous loss of insulin secretion in these patients. It's mostly, especially in those on MDI and so on, and the late institution of pumps. Probably still their T-scores or Z-scores is lower than their counterparts, normal people without type 1 diabetes. And the chronic hypoinsulinemia and low IGF-1 affect the normal maturation of bone. So there have been studies looking at the density, what happens to their bone density as they grow. And the peak bone density is lower than control. And that's why even their bone size, their cortical density, everything is lower than what it should happen. And this is probably related to the chronic hypoinsulinemia that they are subjected to since their early growth years. I stress on the point of peak bone mass in type 1. It's much lower than their normal counterparts.
Okay, maybe I'll ask, thank you very much, Professor Youssef. Maybe Dr. Thamer, there are two questions actually related to the use of osteoporotic treatment in patients on dialysis. You know, there is a risk of hypocalcemia if you have to use agents. So basically, how do you approach someone with end-stage renal disease on dialysis? Let's put it this way, Dr. Thamer.
Well, first of all, it's a huge topic, definitely, and it's not easy to manage when you should endpoint end-stage renal disease, because you end up a lot of times having low bone density, but you don't know why. What's the pathology exactly? Is it that the bone turnover has actually shut down, or that bone turnover is actually excessive? So this is there's several clues that you want to go through to find out if this patient has an adynamic bone disease or osteoporosis with high bone turnover. So patients with high bone turnover, anti-resorptive therapy would be a good choice for them. And for end-stage renal disease, the only option is denosumab. Now, definitely there is a definite increased risk for developing hypocalcemia. So every precautions has to be done to prevent that. So precautions goes into correcting vitamin D deficiency, correcting calcium if there is deficiency, putting patients on supplements of calcium, vitamin D, and even activated vitamin D level, and even scheduling sessions even before, after, the denosumab to improve the calcium within dialysis self. So these are several ways of doing preventing hypocalcemia. If patients have an adynamic bone disease, then these patients could fit into going into anabolic therapy. Teriparatide, even though it's not really defined in terms of dose in end-stage renal disease, but in clinical practice, it can be used in patients with adynamic bone disease. And in the contrary, you don't see much of hypocalcemia.
Excellent, excellent, very good. Really right answered, very right to the point. Maybe if you want to comment on the how frequently do you have to repeat your DEXA scan when you start a patient on treatment, and for how long would you take them for treatment? Like, let's say you started with anabolic and then you moved to anti-resorptive, and you keep them for how long? 5 years, longer than 5 years? Maybe you want to comment on this.
So if patients on anti-resorptive therapy, and most likely they will be on it for several years, probably then you want to do make sure of compliance. So there are several ways of doing compliance. Turnover markers is one way to look at compliance, but it's not really available everywhere. It could be expensive in some locations. So DEXA scan could be actually cheaper than turnover markers in some locations. And looking at BMD value, especially at the spine, where the most sensitive way of looking at changes in bone density is actually could be helpful. And you can do that every 2 years almost. If you're on an anabolic therapy, you could expect a significant increase in the bone density within even a shorter period of time, 6 months to a year. So if you're on a therapy like anabolic and you're really concerned that this patient is on it, you want to get him as healthy as possible with increased density, you might do it within 6 to 12 months just to see the response of therapy. And on anabolic therapy, you can see that change. Definitely, that also goes back to the least significant change in the bone density, which is a technological part of the reading at the DEXA scans, knowing that there is an absolute difference between one scan and the other. If patients on an anti-resorptive, probably for years going to be on it, probably I would keep it every 2 years.
Excellent. Very good. I'll ask you one more question, and the final to conclude, Dr. Youssef, I'll ask him one question and we'll stop. I think there's interesting question, and I wanted to give them the time really for you to answer those ones. Now, for you, basically, do you want to, I mean, it's beyond what you mentioned, but, some people have advising adding K2, vitamin K2 to vitamin D. Do you think really it makes a difference as far as absorption of vitamin D? Would the effect at the end point would be different? Maybe you would like to comment on this.
So the science is still evolving with the use of vitamin K in osteoporosis. And the basic science shows that there is a possible better mineralization of bone with the use of vitamin K within the treatment of osteoporosis. We have not really seen any clinical data showing significant change in bone density, neither the change in the risk for fractures. Neither is also the effect of the regular osteoporosis therapy or the minerals that we use, the vitamins, on the effect on BMD with or without the use of vitamin K. The basic science is really encouraging. I don't see much harm in using vitamin K in majority of patients. A lot of products now being developed with vitamin D and K at the same time. So this could be useful for patients who are really interested in using it. There is no much objection, but we still wanted to know more about the clinical effects to have a better recommendation how to use it.
Thank you very much, really. Really, you answered your questions in a very clear manner. Thank you very much for your feedback. The last question for Dr. Youssef, if you're still with us.
Yes, I'm here.
Dr. Youssef.
Yes, I'm here.
Yeah.
Yeah.
Any treatment that you would propose to revert or stop sarcopenia in diabetic patients?
I'm not an
That's a
expert in
difficult question.
sarcopenia, but let me say this, Ali, and I've seen many diabetics patients with long-standing poor control going into sarcopenia quite quickly. And diabetes is a disease that affects all body organs. We focus on kidney, retina, or heart, but literally every single part of the body is affected, and including the skeletal muscles. So I've seen that patients with
Right.
long-standing diabetes, chronic poor control, will develop sarcopenia quickly compared to their counterparts. We know that diabetes, on average, lower the life expectancy by something like 6 years or to 12 years. And I always tell my patients, if you want to have a better sort of life quality when you get old, you better pay attention to your diabetes control at this age when you're younger. And so the advice is improve your A1C, control your risk factors. Exercise is very important, and everybody knows about this study that showed that
Right.
what you do exercising at this age will make your elderly years much better health-wise. So invest in your future health. That's all what I can say. And paying attention to your health
Right.
is your
I agree
priority,
with you.
your responsibility, and it's your option to control your A1C and live with below 7% or stay 10%. We see a lot of patients with 9-10%, and many of the studies in the Gulf and KSA, 9 is the average. Rarely we see a center which has an average of 7 or even below 8%. So we still struggle with patient control, and that plays a major role in the development of sarcopenia in old age. The attention to vitamin D and proper healthy diet and exercise is the general advice that we give to all our patients to make
Right.
prevent
The key.
sarcopenia from happening.
Thank you very much. Really, I think really for the sake of time, really we extended really your time. I think we should stop at this level. I would like to thank you very much, Dr. Yusuf, Dr. Thamer, and the organizers for really giving us really the chance to go of such an important topic. And actually, till now, we have still 220 attendees really still with us, just to show you how interested in your both on your talks. So thank you very much. It was nice again to see you again, both of you, and I wish you a very good night.
Thank you very much,
To all
Ali.
of
Nice
you.
to meet you, and thank you, Thamer. And do I thank again WIAM and ICOM for arranging this academic activity. Thank you all.
Thank you all. Thank you for the organizing committee, and Dr. Yusuf, Dr. Ali. Appreciate it. Thank you so much.
And thanks, Ziad, for your support too.
All the best, Ziad.
Thanks, Sam.
Thank you. Thank you all.
Have a good night. Bye-bye.
Have a good night. Thank you.